Finally, after all of that, the A&P, the electrophys, how to put leads on, how to read them, how to analyze, let's actually finally look at some rhythms, huh? Well, we're going to start from the top of the heart working down. So we're going to do sinus or atrial rhythms. So that's going to be ones coming from the sinus node, the right atrium, or the left atrium. I'm not really going to specify one or the other than sinus node beats. Just realize that atrial rhythms could come from any one of these locations. So in basic arrhythmia, we talked about really simple ones like sinus rhythm, sinus Brady, sinus tach. Well, here's a third derivation that's actually a little bit tricky to catch sometimes, and that's sinus arrhythmia. And the idea is this: the impulses are released at an irregular pattern, and the rate will increase with inspiration and decrease on expiration. So it's really easy to see in a sleeping patient. The impulse still comes from the sinus node. That hasn't changed. And conduction through the ventricles happens just fine. It's just that there's this varying rate that occurs. It kind of speeds up and slows down. Here's how it works. It's all based on the respiratory cycle. And essentially what happens is inspiration decreases your vagal tone. So what happens is with less vagal tone, your heart rate will increase. So when you breathe in, there is less vagal tone, and that causes your heart rate to increase. When you expire, well, that equals more vagal tone, which drops heart rate. How do we stop this? Well, honestly, if you just have them hold their breath, it goes away because now you're not stimulating this whole cycle. Now, if they're holding their breath and you stimulate the carotid body, it'll actually start happening all over again. So it's just really one of those fun, neat things that happens, but really doesn't have any major pathological weight behind it. So we'll go through and we'll explain a little bit more. So what are the rules for sinus arrhythmia? Well, it's actually pretty simple. It's usually a pretty normal rate. These patients aren't usually in any kind of distress, but what you will see is an irregular pattern, and that's where it speeds up and then it slows down in a repeating fashion, just gently increasing and decreasing. There's nothing wrong with your P waves. There's uniform, there's 1 P for every QRS. Your PRI is normal and constant, and your QRS looks great. So how do you interpret it? Well, we'll start like we always start. And if you're watching, you can already see how it just appears a little bit tighter in the center than it does on the outer parts of this strip. And so I'm going to go ahead and say irregular here. Not massively, just a little bit. And that there's no ectopics. But now that I've done that and I've decided it's irregular, I can just go ahead and add these across and say I've got 8 beats. So we'll just say 8 times 10 equals 80. Now, if I really wanted to prove what was going on, let's go ahead and check our rates against one another, shall we? So we'll take beats 4 and 5 and we'll measure across from them. And what I get is exactly 15. 5, 10, 15 small boxes, and so I'll just say 4 to 5 is 1500 divided by 1. Nope, sorry, divided by 15 equals 100. And then I'll measure way out here on these far ones, where I've got 7 and 8. And that is a situation where I've got 5, 10, 15, 20. And so 7 to 8. $75. Regardless, this is all a normal rate. It's not too fast, too slow, anything like that. We've decided it's irregular, so let's take a look at our P waves. And so each of my P's, I'll just mark a couple of them, all look pretty well upright, uniform, and consistent throughout. But are they consistent? Well, and the answer is going to be no. If I go back through and I do these exact same measurements from here to here, that's 15. And if I measure from this P wave to this P wave, that one's 20. So I have the exact same irregularity that I had seen before. And it matches, and that's good. Then I have 1 P for every QRS, which is good. Let's grab a PRI. Let's go ahead and measure one out here to the side. And so I've got 1, 2, 3, 4. I'll measure one more way out here. Let's go ahead and pick this one. We'll say it's about a half mark. Actually, I'll say that one's on the solid. 1, 2, 3, 4. Again. So 4 times 0.04 equals 0.16, which again is normal. QRSs are all uniform, aren't they? And I've got that QRS pattern. My width on these is going to be exactly 1, 2.5. That's normal as well. So the only thing that's out of sorts with this is the fact that it's irregular. Otherwise, it's a perfectly normal sinus rhythm. And that's why we wind up with the name sinus arrhythmia, the speeding up and slowing down. If I wanted to do one more check on everything, I would do the measurements between 1 and 2 to just confirm if I really needed to. All right, so why are we bothering to talk about sinus arrhythmia? Well, 2 big parts. One, to let you know that it is common in children and young adults, so it's not something to freak out about. And next, more important, is that it's really easy to misinterpret. People call it irregular sinus bradycardia or regular sinus rhythm. I've seen some weird names for it. In fact, I remember the first time that I saw this and I had no idea what to call it because they were actually bouncing between tachycardia and a normal heart rate, and I didn't know what to do. So I share this with everyone just so that you can have an idea of, hey, this exists, and if you encounter this situation, this is what you call it. And it actually makes it fun when you do find one. Clinical wise, what do you see? Well, you see an irregular pulse that, again, it speeds up and then it slows back down ever so gently. Rarely causes symptoms. If you have a patient with vagal tone issues, it may be important to mention that to the doctor that you've seen it, but that's about it. Multifocal atrial rhythms. Unlike atrial rhythm, atrial tach, where you have a single focus that's responsible for all of the beats that are occurring, in this case, the pacemaker wanders around different parts of that heart. So it can be the sinus node itself. It could also be in the left atria and the right atria. You can have a multitude of locations all firing, taking turns, happening at the same time and racing to the door. A lot of different ways to think about this, but each one of them is firing kind of to the beat of their own drum, and which one of them winds up getting through the gate and creating the next heartbeat, well, it's just up to chance. And what this does is it irregularly initiates those impulses. Once they get to the AV node, conduction goes through normally. So your QRSs will look just fine. There's two types. There's wandering atrial pacemaker and multifocal atrial tach, to which we'll go through and differentiate the two next. So the rules for multifocal atrial rhythms. As I just mentioned, there's two major types. There is WAP, wandering atrial pacemaker, and that one is defined of having a heart rate between 60 and 100 beats per minute. Now, if that heart rate should go faster than 100 beats per minute, then we give it the name multifocal atrial tachycardia. It's simply a rate-defined difference between the two. Regularity for both of these rhythms, well, it's going to be slightly irregular because you've got these different P waves each, or different sites for the P waves each taking turns on who's causing the rhythm to happen, and it will not have a pattern. Now, this is the most important part of all of this, is that the morphology of the P waves can change from one complex to the next, and most important, you have to have at least 3 different ones for it to be counted as multifocal atrial tachycardia. If you have 2, then it's just atrial tachycardia or atrial rhythm. But if you've got 3 or more, now it becomes multifocal. Your PRI should be less than 0.20, and your QRS should be less than 0.12. It just should be normal. Other important things to mention, the P waves will return to their baseline and be separated by a little isoelectric interval. The P to P intervals, so P to P, P to R, and R to R will all be variable. They may be very, very close, but most of the time they'll be off by a bit. And then lastly, each unique P wave has its own PRI that will be consistent each and every time you find that shaped P wave throughout. And so let's do some examples so you can see what I'm talking about. Okay, just like we do with all of the others, this is a 6-second strip, and it is in the 2 lead, and we're just going to go ahead and number these because this will come in handy later. Well, does it look regular? Actually, it pretty much does. It might be off by a hair. It's kind of hard to tell. So we're going to just maybe have to get out calipers to figure it out. But let's just go ahead and do the multiplication just to be safe. So we'll do 9 times 10 gives us 90. And let's do a few of them here. So let's measure between these first two, beat number 1 and beat number 2. And this space here is right at 15, which is cool. And this space here is also at 15. But if I measure between 5 and 6, I actually get 16. So it's a little bit different. And then down here, I'm actually back to 15 again. So they're pretty close. Either way, if I divide by 16, that gives me 93. Ultimately, all of these are normal. A little fast, but normal. So I've got a normal rate. It's pretty regular. It's only off by a hair. I don't really have a pattern. I don't have any true ectopic beats, but my P waves look pretty weird. So let's go through here. And so if I compare each and every one of my P waves, I will note that the first 4 are about the same, then it gets tiny, then we're inverted, worse and worse. So those actually have a whole bunch of different shapes to them, really. So I have many types of P waves, but I do have one for every QRS. And if I go through and figure out the regularity, they're actually just as irregular as the QRS R to R intervals are. That's a fun sentence to say, but they're just as irregular, which you can go through and measure if you really want to. But what I do want to do with this one is I want to start identify these P waves. So let's just start with the very first one, and I'm going to label that one A. And so all of the sharp ones that I see, I'm going to label with an A. I'm even going to say that one. And B is awful small, so I'm going to, or sorry, beat number 5 is a little small, so I'm going to give that a different letter. 6 is actually upside down, so I'm going to give that a C. And this one's even more pronounced. This one's flat, if anything, so I'm going to call that D. And this next one's inverted completely, so we call it D, and also inverted. So that I've got A is sharp, B is small, C is flat, and D is inverted. And so that's important to note. So if I had a longer strip, say 18 seconds or longer, or I looked at it maybe 10 minutes from now, I could take these same letters, A, B, C, D, and apply it to that strip and see if I can find that same pattern or information through there. Now, with each one of these, I need to get a PRI measured. So for A, B, C, and D, let's see what we can get. And so for A, I'll just go ahead and measure this first one. We'll say it starts right around here. 4, 5-ish. Let's measure another one. Yeah, I'm going to say 5. So that one's 5 small boxes. And let's see what B has to offer. This one is 2, 3, 4 small boxes. Let's see what I can get for C. Oh, that one's got 3. And I'm going to measure this one here. It's pretty easy to tell. 1, 2, 3.5. So if I multiply these times 0.04, all of those are actually normal. Last but not least, let's go take a look at our QRS, and we can actually look off this entire screen that all of those are uniform regardless of the P wave that's in front of them. So we will go ahead and say we have the tiniest of Q waves on some of these. So we're going to go tiny Q, big R with no S. And if we measure these out, we'll just go like that and that. And that's a 2. So that is, oh, there's no ectopies. So that gives us wandering atrial pacemaker. Okay, so let's take another look at multifocal atrial tachycardia, also known as MAT. How do we do it? Well, this is a 6-second long strip. It's obviously irregular. So let's go ahead and count these out. 1, 2. Tachycardic. Do I have any ectopy? Well, that's a little bit hard to say because there's so many early beats throughout here. And so I'm going to say no to ectopy for now because it's so junky, but I can also say no to a pattern because there's really not a discernible one at this time. So let's take a look at our P waves. And once we start looking at those, man, they are just all over the place. It's hard to find any two that look alike. So we can say that there are many. But it looks like there's a P wave for every QRS, just about. 1P for every QRS. All right, what's up next? So let's just go ahead and start labeling these. That's the best thing to do in situations like this. And so beat number 4 has a nice sharp looking one. So let's go ahead and name that A. Beat number 5 has a sharp one. 6, it's a little hard to tell. 7 is sharp, so we'll give that an A. Number 9 has a sharp one. And hard to tell with 10, 11 definitely doesn't. Don't know about 13. 12, 14, that one has a sharp A. And that's pretty much the only ones through there. So let's take a look at another one. Back here on the far left, we'll notice that this one actually is a little bit inverted, number 2. So we'll just go ahead and call that B and see if we can find any other flattened or inverted ones. You know, and number 8 kind of has that inversion, especially if you imagine the artifact being gone from that. So we'll call that a B. And do I have any other ones really? No other inverted ones. Is there a third type? Is there a third unique one? Well, I'm actually going to go with beat number 11 and say that C, because that has, it's not as peaked as the others. It's not inverted, it's just tiny. So we'll call that type number C. So we'll say that A is sharp, and we'll say that B is inverted, and that C is small, or flat, however you want to call it. But the upside is there's 1P for every QRS throughout here, so we did establish that. So let's talk about our PRIs. So we've got A, B, and C. And so we'll start with A's. One, two, three. What else do I have? Let's measure another A. Number 7. 1, 2, 3. So pretty consistent. 3 small boxes there. We only have a couple options for B, so let's go ahead and let's do the clean one first. It's a little hard to tell because it's combined with the T wave, but we can say 1, 2, 3 for that as well. And as near as I can tell, if I go 3, 2, 3, that's about where it starts. So I think that's reasonable as well. And we only have 1 to go off of, but let's go ahead and measure C. It starts probably around there. And that has 3 as well. This is actually a trifecta. So that's kind of unique to have all 3 be identical, but they're obviously extremely different. So it's kind of hard to say that that's not correct. But you take that times 0.04 and you get 0.12. And so we've measured that they're not only consistent with themselves, each A has the same PRI, but A, B, and C all also have the same PRI. So that's just good information to know, especially since all of it is normal. So let's take a look at our QRS, and it looks like almost every single one of these is the same except for number 10. That one has a little bit different shape than the rest of them. So let's say by and large though they are uniform except for number 10. They have the same pattern of R prime. Actually, 1, 2, 3, 4. Actually, let's scratch that, and that's actually R. actually R prime, because it's less than half. And it varies a little bit throughout here, but we'll say the R prime. And what is the QRS going to be for these? Well, let's go ahead and measure that and that. And that's at a 2. And I measured on number 6, but if you check any of these, even number 9, that's right at a 2. So those are normal. Now number 10, if we want to take a closer look at him, we see that he has what's actually R prime, where the second R is taller than the first, which makes it a little bit unique. Now, is that an ectopic beat? Well, it is a little bit early. We can definitely tell that. It's smushed up next to the previous one. And the reason why we weren't able to label the P wave on this one is because the T and the P wave are combined. So it's kind of impossible to tell what shape that P wave might be. But I can tell you that your QRS is also 2. So with a normal QRS, and we can suppose that the P wave is trapped into the T wave so that it had a normal start, this is probably just aberrant conduction. Which makes sense. When you have fast rhythms like this, that aberrant conduction is far more likely to occur, right? So that makes it normal. Now, as I just mentioned, you saw how I'm not able to label all of the PRIs because some of them are combined with T waves or mixed in with other ones. Number 5, I actually could see the T and the P separated. But for here, it's a big question mark on 6. I'm not sure what I'm looking at. Same for number 3. If you look down here, of course, number 10 is a question mark. Number 12, and even number 13, I'm not quite sure. And that's where having a longer strip would be more helpful because there's more opportunities. But at the end of the day, this is multifocal atrial tachycardia with some aberrant conduction. So why are these multifocal atrial rhythms important? Well, most episodes of MAT don't really cause hemodynamic compromise or any kind of limiting symptoms. However, those higher heart rates associated with it can sometimes worsen your systemic oxygenation, especially if they've got pulmonary disease. And in fact, pulmonary disease is one of the causes of MAT and WAP. I should consider these both simultaneously. Multifocal atrial rhythms in general tend to happen in pulmonary patients. So if you wind up going from a WAP into a MAT, that increased heart rate just makes everything worse for what we've talked about before, because that decreases your diastole, which is your relaxation time, and all those different things. Additionally, if you've already got coronary artery disease on top of everything, well, that's just going to lead to another cascade, especially if you have heart failure on top of your cardiac disease. And let's be honest, most of our patients have a combination of all of that in some way, shape, or form. And so here's the big things. If you are symptomatic, so if you have symptoms, we are going to treat the tachycardia and get that slowed down. But if you're asymptomatic, we're going to treat your primary condition to try and improve things that way. And that's just something interesting to know about these types of patients and what we can do to try and improve what's going on with them. Other important things just to mention, your associated conditions, the pulmonary, cardiac, low potassium, it's never good, low magnesium, since those two go hand in hand, not a surprise. Alright, so this diagram here is to help you get a deeper understanding of exactly what a flutter is and how it's built. And the idea is this: you have a single starting point, which, let's just say it's right here. That single starting point fires, and when it does, the impulse travels in a circular fashion, counterclockwise, around the inside of the right atrium, which is what we're looking at over here. And just as it's coming around the bend, it slows down a little bit, but then just as that initial point has gotten through its refractory period and is ready to fire again, boom, the next one hits it. And so you wind up with something that looks like this, where you have an initial impulse that travels in a circle around this way. And then just as it arrives, it triggers a second impulse that then travels around. And then just as that one comes around the bend and is able to stimulate and react, the next one loops through. And that's what we talk about, that cyclical re-entrant rhythm, is that it's a self-perpetuating heart rhythm. And so what that does then is that's what causes it to make these flutter-shaped waves, where you get the flutter, the sawtooth specifically. That's what makes this really cool. And it's that absolute refractory period that really kind of judges how quickly this kicks through. But it is rapid. It's as fast as the heart can physically recharge itself and go again, which is why you're looking at rates of 250 to 300 beats per minute in the atria. Now, for the advanced class, we'll continue on with this particular strip because there is a boatload of aberrant conduction going on with this RVR patient. In fact, AFib with RVR is a really great source for finding aberrant conduction. So let's take a look and try and figure out what native beats there are. And the native beats are the ones that are going to look more natural. So I'm going to go ahead and say that the native beats include 3, 6, 8, 9, and 10. And that's because they have the RS pattern to them. So that's 3, 6, 9, and 10. Now, as for the aberrant, those have more of an R prime S pattern. And so those are going to be, I'm going to go ahead and put A next to these. 1 and 2, 4, 5, 7. I'll have that RR prime layout for them. Now, granted, number 2 is a little bit different from those because its amplitude is a bit off, but because it's sandwiched so close in between some other ones, I feel like that may be what's causing it. Either way, yeah, that's what I'm going to say for that. So we have 1, 2, 4, 5, and 7. Decreased cardiac output, CO, may present as which of the following? Will it show up as chest pain? It absolutely can, because that heart may not be getting the perfusion it needs. Hypotension? Absolutely, because if the heart's not putting out enough blood pressure, you might, or not putting out enough force, you might have low blood pressure. Decreased level of consciousness? Absolutely, because you're not getting enough blood flow to your brain. Shortness of breath? Definitely, because it feels like you can't catch your breath, either because blood backing up or because it's not moving well enough throughout your body. And anxiety, you don't feel good. So these folks might even just show up super anxious, and then you figure out all this other stuff. So yeah, essentially all of these are items that may be present with decreased cardiac output. Your patient started the shift with rhythm A, and later the alarm sounds and you see rhythm B. And the question is, what would be the most appropriate action with this rhythm change? First thing you need to do is figure out what two rhythms you have. Take a second, figure it out yourself. Go ahead and pause, but I'll give you the answer right here. Your top one is sinus rhythm with PAC, and it turns into a fib with RVR, rapid ventricular response. You've got a heart rate greater than 100. And so now, is this emergent? Is it non-emergent? Well, it's a rhythm change, not for the better, so it's definitely not a false alarm. That's not artifact or anything, because you can see how irregular it winds up being. Notifying the CNA of the rhythm change isn't the right approach either. Is this a lethal arrhythmia or something that's worth turning into an RRT over and have the ICU nurse go evaluate the patient right away? No, it's not that dangerous, but it isn't good. And so now you have to decide, is it non-emergent? Well, I'll just let that primary nurse know when I have the chance. Or is it emergent? Then I'm going to immediately contact that primary nurse and escalate if I can't get a hold of them. And honestly, I think that's the right answer. It's a thing that when your patient goes into AFib, it's never for a good reason, and you want to be able to make sure that the nurse is aware of it so that they can do whatever interventions may be necessary, whether that's anticoagulation or whatever. So please keep that in mind, and there you go. Your patient started the shift with rhythm A. Later on, the alarm sounds and you see rhythm B. What action would be most appropriate? And so for monitor techs, what are we going to do? Well, is this appear to be a false alarm? Nope, not at all. Is this an emergent change? Well, you really have to figure out what is your rhythm? So I'll give you a second to look at it, pause if you want, but I'll go ahead and start saying it now. We're in A Flutter, and it's a little bit of a fast rate. And here we go to sinus Brady with PAC. And we've got 1, 2, 3, 4, 5, so we got a rate of about 50. So, again, is this emergent or non-emergent? Well, it's non-emergent because they've actually gone to a better rhythm, so we don't have to worry about either of those. And now we ask the question, do we have the CNA look at this patient, or do we have the primary nurse be the one who gets notified and have them look at the patient? And that's the truth. This is not for a CNA to deal with. We need to notify the nurse themselves so that they can do the rest of their job.